patients of like noticing, is this person able to identify emotions or not? Right. And that if they can't, that there has to be some kind of effort expended to help the patient to be able to do that. And in one way, you know, emotion-focused therapy also does that. But there's a little bit more of a degree of comfort with the therapist being a coach who kind of educates the patients. And I think true to psychoanalytic roots, ideally, we like to try to encourage a patient to be able to name their emotions themselves.
In one of your chapters, you say that there's a bit of difficulty in thinking about a therapist or an analyst telling the patient how they're supposed to experience or how they we both agree there's many different definitions of interpretation, but I think in the context of how to reflect back to the patient on what you think is happening for them.
That's right. I mean, so you're owning that this is how things look from your perspective, which sort of stops short of, you know, encouraging the patient to believe what you think that they feel. Mentalizing is dialogical, is relational. It helps to have someone else be working with you to help you understand what you feel. Right? That it's not something that, you know, is sort of, again, just always intuitive or obvious.
Well, I think what you're saying in terms of the same thing is for the child model and all, I think, interventions using mentalization, that the relationship and creating what we call epistemic trust. You know, creating the belief that what you are trying to express is interesting to the other person.
That's right.
And I think there's been an assumption that a lot of our adult patients come in, other than the ones that come with like very clear trauma. You know, there was an assumption that if you were of a certain personality organization, you already had that experience.
That's right.
And I think the modification of technique is so important in that sense.
That's right. Yeah. I mean, if someone's epistemic trust is not functional or operative, it means that they're not going to hear what you say, regardless of how accurate it might be.
The issue of like scaffolding in the way that you described is much more benign towards the patient and the therapist. Because I think there's no therapist out there that could say that they haven't had 1 week where they have felt like, what am I doing?
It's important to appreciate how mentalizing is something that I think almost has to happen in a treatment that is successful. Right. You know, if you think about the field, you know, we used to have ideas about someone being well analyzed as if there's a kind of, you know, sort of absolute knowledge that
gold standard
is accomplished by the end. Right. And, you know, that was accomplished through insight or the project of reconstruction. You know, those ideas have been challenged by the relational paradigm, but the relational paradigm also kind of falls short in just suggesting that it's the quality of the relationship that determines what happens.
I mean, classically, we always say the main aim is self-observation, right? Here we're adding something, right? We're self-observation in collaboration and in the context of a relationship, but with somebody whose hopefully capacity to self-observe also their own emotions, their own, you know. I mean, that's the other thing I wanted to ask you, because it's of interest to me, the role of this concept of mentalized affectivity in the context of countertransference. Because I think, you know, again, as someone that works with adolescents, you know, they're challenging my capacity for mentalizing all the time.
You know, it's easy to think about mentalizing as being sort of preventive or prospective, that it sort of allows us to make the right choice, you know, maybe in the face of being challenged, let's say, by a difficult adolescent patient. But I think the reality is that mentalization is often retrospective, that in a kind of funny way, we begin to mentalize when we realize that we should have mentalized, but we were unable to do that.
That's right. That's right.
And so, you know, that's where mentalizing can be very helpful in terms of maybe you didn't respond so well in the moment, but being able to kind of face that and think about, you know, different ways that you would want to respond.
And that's why I wanted to bring up the implications for clinical practice, you know, because one of the things that I think is difficult with the books and mentalization theories, that a lot of them, because it's so important, the research that has gone into them, right? Sometimes people just find them very difficult to read. And so I thought this was great for us to sort of demystify a little bit, because I think for both of us, I mean, for me, working this way has really changed my practice. And has really allowed me to, in a way, keep in mind things that sometimes maybe we take for granted in a therapeutic relationship. I mean, I was being trained in a classical way at the Anna Freud Center when these ideas were emerging. And as someone that primarily works with parents and children, they really spoke to me. Do you think your ideas from that time to now have changed significantly?
Yeah, I think the theory has evolved. And, you know, the fact that it's changed, I think, is reflective of that it's living, right? In the 2002 book, we came close to the idea that mentalization grows out of secure attachment. There's been a wealth of empirical literature on early mentalizing capacities, which would put that into question. I think we also have a slightly different way of talking about borderline patients. You know, again, we were probably too comfortable kind of thinking about borderlines as failing to mentalize rather than that there's almost some antagonistic relationship between mentalizing and attachment, where it's not that they can't mentalize, is that it's that they can mentalize, but under certain situations, their attachment systems interfere with that.
That's right. And they return to more pre-mentalizing modes. You know, my favorite definition of mentalization is observing yourself from the outside and the others from the inside. Right? And but with this book, you've added the dimension of, you know, really doing that while looking at emotions specifically, and as a clinician actually taking the time, you know, to define what you just said, define what can this patient do, and where am I going to work.
That's right.
You know, and how, and it does move a little bit away from this belief that negative emotions are to be run away from, like the defense.
It remains the case that, you know, again, you can criticize psychoanalysis in many ways, but in trying to articulate the value of negative emotions, that it really is a sort of distinctive a recognition of the value.
I think you give a human face to the theory of mentalization with your book, because you use the, you know, you're a philosopher, and it shows, and help me at least expand my understanding of this wonderful concept.